maneuver it out.
Yeah, exactly. So the objectives here, we want you to be able to define shoulder dystocia and basically be able to tell us what you're going to do in the event of shoulder dystocia, how to manage it. So really that's the only goals here. And I also wanted to just briefly touch on the different kinds of maneuvers, and there's some anticipatory signs that you can tell when a baby's going to become stuck, so we'll talk about that too. First, I want to talk about the risk factors. What do you think some risk factors for shoulder dystocia is? First of all, a baby that's a big baby, greater than 4,000 grams, a mom who's had previous shoulder dystocia, pre-existing or gestational diabetes, a maternal obesity, post-term delivery, excessive weight gain during pregnancy, slow progress of labor, prolonged second stage, and when we use forceps or vacuum, sometimes the shoulders do get stuck then too. Anticipation is key. Although there are risk factors, it's an unpredictable situation. So act fast, don't panic. You're gonna immediately call for help. The doctor's gonna tell you what to do. So what we do here at L&M is we just say, basically pull the call light and say, Dr. McRoberts to room 440, or whatever room you're in. So that's where we start. You wanna have a pediatrician in the room, and the doctor's already gonna be here because they're doing the delivery. And you're gonna definitely anticipate the need for all these maneuvers we're gonna talk about next. Let's see, fundal pressure is absolutely contraindicated in shoulder dystocia. Anyone ever tells you to do it? Do not do it. It's very, very bad. All right, so the first, sorry, I'm on technical difficulty, is McRoberts maneuver. So that's the first maneuver we're going to talk about. It's the simplest. It's the first one we always go to. And basically what you're doing is there's going to be a nurse. You've already called for help, so there'll be a nurse on each side of the patient. So you take the legs and you're going to pull them back towards the maternal abdomen, increasing the dimensions of the abdomen, of the pelvis, to try to get that baby out. So that's the first line. The next one, if that doesn't work, which it usually does, right, girls?
Oh, yeah.
I mean, it usually works. If you do McRoberts, that's usually all you'll need. But sometimes it does have to get to where you give suprapubic pressure, and the doctor will tell you. So if you're each holding a leg, and he wants pressure to the right or the left, whoever's on that side will apply the pressure, and you're gonna use a closed fist and while doing so. And you're gonna push right above the pubic symphysis toward whichever way the doctor tells you. So that's suprapubic pressure. The next maneuver is called Rubens 2, and that's used in conjunction with McRoberts and suprapubic pressure, where the doctor puts his hand in and tries to internally rotate that shoulder. So there's also something called Wood's corkscrew. It's when the physician rotates the posterior shoulder, flaps it across the chest, and then pulls the baby out that way. I know that sounds a little gross, I'm sorry. 180 degrees to dislodge the anterior shoulder. As a last resort, the physician may attempt to deliver the posterior shoulder first, and that's when he sweeps the arm across the fetal chest and pulls out that way. There's a rare maneuver that I've never seen used, but we have to learn it. It's called Gaskins, and basically you're putting the patient in all fours and try to deliver that way. The last one, this is a very, very rare maneuver. I've never ever seen it used. I don't even know anyone who's seen it used. It's called Zavanelli's, and that is when the fetal head is already out. So the physician is going to take the fetal head and push it back up into the pelvis and prepare for an emergent cesarean section. And that's under general anesthesia. It's usually got a terrible prognosis, and we don't ever do it. Have you guys ever seen? No. So those are the basic maneuvers. Let's see. So now I want you guys, I'm going to give you a scenario. You guys want to come up? you're gonna be who we call for help, so, do you have the nurse? Is that okay?
Yeah.
Alright, so this is Miss Joelle Doe. She's a 21-year-old G1P0 at 37 and 4 weeks gestation. Her prenatal course was complicated by maternal obesity. Her BMI was greater than 36. Her 1 hour blood sugar, glucose tolerance was normal, and she is GBS negative. She presented with a rupture of clear fluid approximately 8 hours ago and was noted to have irregular contractions. She was placed on oxytocin and progressed to fully dilated and a +2 station and has just started pushing. The fetal heart rate tracing has been overall reassuring, and she quickly progresses to crowning. The room is set up for delivery and the physician is called. And now we're here. Okay, so pushing.
Oh,
Turtle head.
the slippery head, I forgot there's lube on here. Come in, keep pushing.
This is called what we call turtle sign. So the baby's head is going to come out, and then when the uterus relaxes in between contractions, you're going to see the baby's head go whoop, sucks right back up. That's called turtle sign, and that's an indicative of shoulder dystocia. So I'm going to keep going. Baby's head's out.
Okay. And then we have a shoulder dystocia.
Okay, call for help.
Call for Dr. Roberts for recording.
This. All right, Miss Roberts, legs way back.
Oh.
Push, push, push. Keep pushing. That's not work. Is it gonna work?
Yep.
Oh, okay, that'll work.
Woo. Woo. Next time, Ellen. Okay.
And there's
All
your
right.
baby.
Woo. Okay, so now I want to just show you
I was
how we
thinking it's
do suprapubic pressure. So let's get that placenta back out.
Deliver the placenta.
We'll move this baby back up.
It's intact.
Okay. We're going to do this again. This time it's going to look a little bit different. Okay. So baby's head's coming through. Still, you're noticing the same thing. When you see the
Turtle
turtle
sign.
sign. Pushing for a long, long time.
Pushing. Keep
Okay,
pushing.
heads up.
Okay, heads out. Oh, it's tight.
Make
All right, we have
Robert.
a shoulder dystocia. Need the legs way back. Oh, okay, that's not working. We need suprapubic pressure to the right. There you go. Keep pushing, Mom. Push harder. There we go.
Woo.
Oh,
Whew.
Slimy baby.
sliding.
And that's it. Key points to remember. Never do fundal pressure. I don't care who says what.
If sometimes they say fundal pressure, but they mean suprapubic pressure. So you would never push here. You'd only push here, especially if there's a shoulder distortion.
And use
Get those
a,
legs way
Sometimes you're
back.
jumping on the
Yep.
head with your patient.
and use a clarifying question to the doctor to say, did you mean suprapubic? And you want to hold. I know this dummy has no real legs, but when you're pulling the legs back, you always want to hold the foot with an open palm. Do you guys do that?
The heel, yeah.
Yeah, hold on the heel, because you can cause hip problems if you're pushing way too far back on the foot. So, that's all I got. Thank you.